Okay, good morning, everybody. Let's get started. Uh, so this is your first session in chemical pathology. I think you had a session previously with Sanita with respect to the laboratory tour, correct? Good morning. Um, so first of all, let me just ask a question really. Has everybody gotten access to my learning with respect to the 3314? Yes, yes, okay. So everybody has seen a lot of information on 3314, right? Correct. Good. So please be careful when you have a lot of information. Sometimes we tend to assume that we have everything there, right? And we don't need to attend, or we attend, but we don't pay too much attention because we already have everything sort of recorded. My advice really is to follow based on the schedule or follow based on the topic that is actually given so that you pace yourself because you have all the information. It's almost like having a textbook right there. And you can't learn everything overnight. Okay, so you shouldn't really um, delay learning if you have your required information. Okay, so what you'll see on your My Learning page is actually a outline of the clerkship. I think. Okay, I have to put it in PowerPoint in order to present it. So maybe Monday I'll bring it up in PowerPoint and go through the overview of what I am actually teaching in the clerkship. Basically, your four main topics. Basically, so I'll mention that on Monday when I put it on PowerPoint and bring it in in this room. Also, you see there on your My Learning page for 3314, this particular lecture here, which really deals with pre-analytical error and urine collection, is actually recorded. The full thing, by and large, over 90% of it is actually recorded, and a few points which I deal with in class. So I hope people had an opportunity to listen to it. In fact, it's nice to listen to the recordings before come to class once they exist, so that you're better able to answer questions. So has anybody managed to listen to the recording? Yes, any feedback from My Learning? No, not seeing any answers in the chat. So, out of my chat. So please, if you haven't, go back and look at the My Learning and listen to the actual presentation. Right? Okay, so let's get started. Here's some of the points I want to highlight. Okay, so as I said here, and we would reinforce it. If you go in the library, we have books of various titles, clinical biochemistry, chemical pathology, clinical chemistry. Make sure you're familiar with the particular title. Any of those titles are the same. It all depends on which part of the Atlantic you're on. Right? I think I mentioned that in the recording. Okay, so like in Canada, for example, you probably hear more about clinical biochemistry. In the UK, chemical pathology. Of course, we are UK based in a sense, and in the US, you hear more about clinical chemistry. No one has a title chemical pathologist in the US. You have the clinical chemist in the US, really. Okay. So all those books are the same, right? Just have a definition of what clinical biochemistry is. That's pretty clear. And by now you're getting a hang of this. This slide will become very stale for groups going forward. So what session, what class you had before this one? Anybody? What heme? Right. Okay. So you have done heme. So this is get my pointer. Right. So you've done heme. Right. This is hematology. So you're doing chemical pathology now. So then you're doing your histopathology and part immuno and microbiology. So all of these are laboratory services, right? That underpins medicine. Okay. So in medicine, you actually, as I said, let me put this in context: the history clinical examination. You can make a diagnosis at that stage. Failing that, then you need to use your assistance of your imaging, your physiological laboratory services, and that's what you're going through now. Okay, so when you get the year 4 and 5, when you see a patient who's likely have a laboratory request form, and you have to tick something. You may need hematology requests, you may need microbiology requests, whether it's a urine analysis, or some immunology, or you may need some autopsy, or you may need your clinical biochemistry. So you have to going through the laboratory basis of medicine, and sometimes you have to call that you have to dealing with what you call laboratory medicine. Okay, that's another term for it, and that helps you focus you on the fact that this is actually medicine. So as far as clinical biochemistry is concerned, you have the emergency services, core biochemistry, and specialized needs. Okay, so just one point I need to reinforce and stress there And that's the difference between this sort of artificial difference between the core tests, specialized tests, and emergency tests. Very important to appreciate, for example, you see glucose here exactly go emergency and core. So the question is, why is the glucose emergency and why is it also a core test? And I think I pointed it out in the recording that that's basically depends on how the patient presents. Yes? So if you're presenting with in the emergency room and you physician thinks that you have your abnormality in your glucose levels are pretty high or pretty low, then that would be an emergency test. Whereas if you're coming into clinic after you have been on the ward being managed for diabetes or some other derangement, glucose derangement, then that would be a routine test or core test. Yeah. So when you finish your rotation in clinical chemistry, all of these core tests would have to be covered. Yeah. Well, for example, you've done so far your CK or say cardiac biomarker. We're going to review that on Friday. We wrap that up. Your blood gases, you can see we actually did that. Yes. And you will actually go your water and electrolytes. Don't forget that from year one. Eh? So let me just give you a heads up. Eh? So as part of this class, you're required, right? You're required to go back to year one and make sure you appreciate your water and electrolytes lecture. Hope everybody got that. We're not going to do that again. We're not going to go back to year one. You need to go back and read and refresh your memory on water and electrolytes. Okay. And we can actually come to this here bilirubin liver function test later on. What's special about specialized tests? I think that is in the core. Yes, these tests tend to be batched. It's not often that we actually do a lipoprotein or analysis on a day-to-day basis. That's something that you may, or DNA analysis. Because it's for cost effectiveness, you tend to batch those tests and maybe do it once a month or depending on the volume that's coming in to make it economically feasible. That's what drives this. As well as sometimes the methodology. Okay. In the past, some of the methodologies involve radioactivity. So you put those tests in a special room for health and safety reasons. So you call those specialized tests. Yeah. So I hope you appreciate that sort of difference. But by and large, most of the tests are done routinely in the core lab. The core lab meaning there is a building that's actually designed and dedicated towards a laboratory test, and we do have that in Building 4 and 5 in Mount Hope. Yeah. Specimen collection. So we have the various color tubes, and what is the added information here? You've done this a bit in year one, okay? But the added information is you need to go and somebody else does a presentations on tubes. You can actually go and read up on various types of tubes. I just want to point out one or two things was pointed out, hopefully in the presentation recording earlier. One is the great up tube. The added information there, we have known this from year one, your fluoride and oxalate, and how your fluoride inhibit glycolytic enzymes, and your oxalate is the anticoagulant. And the other information here is that you need to appreciate that great up tube is used to do analysis for what? Anybody listen to the presentation? What else do you use great up to analyze for? Because we all know glucose. Yes, that's a common one. Everybody knows glucose, but it's also used for alcohol. Okay, so don't forget that. Also used for alcohol. That's very good, very good. Keep that in mind. They tend to forget that one. Okay. Green top is usually heparin, and as I mentioned, blood gases. Sometimes you get a little blue top coming in there, so be careful. Yeah. The added point there about this green top tube is that please note, do a little more research. They may be light green or deep green. Okay, which one is lithium heparin and which one is sodium heparin? So green in general can be lithium heparin or sodium heparin. But please know the difference. For example, if you're doing a stat sample, immediate sample, you may need to use obviously you're going to need a green top tube that contains lithium heparin. Why? Because you don't want to falsely elevate that sodium. Yeah, if you're using a sodium heparin tube. So that's very important. So those green is heparin, and also what else you use a green top tube for? At least in our setting here at Mount Hope, for green top tube, we use a green top syringe or green bound syringe to do your blood gases. Yes, arterial blood gas. You mentioned that, and that green has either lithium heparin or sodium heparin. So, right. But what else do we use green tube for? Not just a syringe, a green tube. Yes, it's cardiac marker, exactly. So you can use troponin for green tube. Don't forget that. Yeah, don't forget that. So in other words, the point I'm making here, go and actually look up, 2 points. One, you need to be familiar with the colors of the tubes that you use in your hospital, whichever hospital, wherever part of the world you're working in. Okay, you need to know what is the color of those tubes and what they analyzed in. Yes, and also you need to look at one other thing I didn't mention here. Hopefully I mentioned in the recording is also what tube they use for trace method analysis. Don't forget that trace method analysis. Yeah, can't just use any old tube because you're analyzing for trace metals, small amounts, trace metals. You see, if the tube is not designed for trace metal analysis, you can actually get falsely elevated values as the needle goes through the bung in the syringe. As the syringe or needle, as the needle of the syringe goes through the bung to actually put the after the body fluid in the tube, you can actually get contamination. Okay, contamination. So read up other tubes, things like the black tube, the speckled tube. Yes, all of those are tubes. Please be familiar with them. These here are the most common one in our environment. Everybody knows EDTA. Right, good. Biochemical tests, diagnosis, prognosis, and screening. So please do a little more reading on this. Okay. And the major reading is indications for screening tests. Please know the indications for screening tests. Why would you do a particular screening test? Or when would you do a screening test? Or put another way, what conditions would you screen for? For example, PSA screening test. The answer is yes, it can be a screening test, but it depends on what population are you going to use it in. You want to use PSA to screen for young males. It doesn't make sense. You're going to use it for elderly males. Yes? So let's just go through this surely. Diagnosis, almost any test can be used for diagnosis. Prognosis, key one, tumor markers. That's tumor markers are not used for diagnosis, they're used for prognosis. And typical scenarios which I always mention, basically, if you have a malignancy, a condition, your tumor marker at that level behind, then you have some intervention. And once you have the intervention, the tumor marker level is actually going to come down. Yes, whether that intervention is surgery or whether that intervention is chemotherapy or radiotherapy. And so going forward in time, you're actually going to be monitoring your tumor marker level. And if the tumor marker level suddenly starts to inch up again, then that would indicate poor prognosis. And that makes sense. That means the tumor is actually coming back, okay, or maybe having a metastasis. Okay? So that's prognosis, diagnosis. Screening, read up on some typical screening tests. I mentioned one already, PSA. Yes? But what other tests do you think of for screening? You can screen, for example, for neonatal hypothyroidism. I think I mentioned that as well. So in other words, you're going to screening test would be TSH. We'll have to come to thyroid function test later on in the next block. But certainly TSH, you can actually screen for. Okay? And indication for screening, please note you're going to screen for a medical condition that you would not normally pick up on a routine basis. That's one. Not normally pick up on a routine basis, but a condition in which you have a treatment for. So in other words, a condition where if you don't pick up, you can have almost a reversible negative effects. But if you pick up, you can actually treat and prevent. Okay? For example, cretinism, neonatal hypothyroidism. If the individual is a hypothyroid and you don't pick it up, you can actually have irreversible brain damage. So you want to screen, do a sensitive TSH in the neonates, and if it's the problem with the thyroid, then you can actually have hormone replacement, and it can prevent that irreversible damage. Okay? So I've mentioned PSA, I've mentioned TSH, screening for neonatal hypothyroidism. And another thing you can screen for is PKU, phenylketonuria. Okay? So you may want to read up on PKU as another screening test. These, be careful, we're talking here about biochemical screening tests. Pap smear is also a screening test, but that's not biochemical. So sometimes in an MCQ, if you're in a hurry, sometimes that's one of the options which are the following, screening, biochemical screening test, and you'll see PSA in there, and that's not correct. So that's one is false. Yes. So please read the question carefully. Okay. So then they have everything: diagnosis, and make sure I get everything: diagnosis, prognosis, screening, and treatment. Well, almost anything for treatment, basically. Right. Laboratory request form. Anything to add on that? Age and gender. Yes. Please go back and reference info from year one. Yes. That is your responsibility. Reference interval. Specimen container. Date and time of collection, all this is important. I think we went through that in year one. Okay. Clinical reason, drugs, all of that is important to put in on the form in order for the lab to make sure, sort of a quality check to make sure that the result is a compatible result. For example, someone is let's look at the second to last one. Like someone is taking Lasix, for example, this is furosemide, because of maybe the patient has a heart failure or somehow edematous condition, and the physician is treating that with Lasix furosemide. So, furosemide has a side effect of bringing down your potassium. So you can actually do a quality check, look at the blood report, look at the electrolyte values. You see your potassium is a bit on the low side. You see a history there, patient is on medication, and specifically on furosemide. Yes, this blood picture is in keeping with the clinical history of this patient. So that's why history is important in your lab request form. I hope that makes a little more sense. Yeah. Biorhythm, don't forget that one. Circadian rhythm, for example, cortisol. Yeah. So you need to state the date and time of collection. We did that in year one. You mentioned the sex hormones, as well. I think this has a circadian rhythm. We need to do date and time, right? So that we can properly interpret the results, and that include those reference intervals, on the lab request form. Yeah. So is it what time of the cycle is it? Right, so your estrogen or progesterone can actually say, well, this is appropriate for this particular time of cycle. So that's important as well. Okay, pre-article error. I think you mentioned all of these. Wrong patient, and I'll review this coming to the end. Blood in the wrong tube. Yeah, we'll come to that. We have some examples of next few slides dealing with this. Stasis, delayed separation, wrong transport conditions. Right? We mentioned this already for transport conditions, that's blood gases. And we know the transport conditions of blood gases basically being, it should be transported on ice, obviously. Capped, meaning there should be no air above the blood sample, right? And transported immediately to the lab for analysis. But as I say, I use the common sense here basically, because if you have a point of care machine in the intensive care unit, for example, and there's no real place to walk, you're not walking across 2 or 3 blocks or buildings to go to the lab. Right? The machine is right in the next room. You just simple the blood in your blood gas syringe, and you just put it in the machine, and you do your analysis immediately. Yeah. So that's just a little, the practical and reasonable. Okay. Because these are just guidelines. You need to use the guidelines appropriately in your particular circumstance. Right. So here, take a minute to look at these. Examples of that's a big topic here, pre-article error, right? I didn't go through this in detail in your presentation, so now's the time. Look, this is pre-article error due to site of venipuncture. Pre-article error due to delayed separation. So take a minute and look at both the top one and then below, and then we talk about it. See if you can figure out what is happening with the site of venipuncture. Look at the infusion arm and the other arm, and then make some comments. So I'll keep quiet for about half a minute so you can think about it, and then we talk about it. All right, so let's do right. So like we'll just put in the chat that most people are seeing everything in the chat. That's quite correct. The glucose results are elevated. Maybe they took the sample from the site of the 5% dextrose infusion. Right. So that's one point. This is correct, correct. As you can see here in the infusion arm, 54.2. Okay? So most likely they have took it from the side of the infusion arm compared to the other arm. And what's the other point you notice about this? So that's correct. That's point one. And the other point, right? And You're right. So that's the other point from Joel that said the infusion would dilute the electrolyte. That's quite correct. If you note, everything here in the infusion arm is diluted. Yes? Compared to the other arm. So those are the two main points for that. So the other thing is what's the take-home message? And the take-home message would be to, when you have to take blood from such an individual, the real situation on the ground is that as you approach the individual with a needle and in hand, or to system in hand, they'll complain, Doc, another stick, I just get a stick for it to put up this IV. And you want to feel sorry for the patient and take blood from the infusion and you get the wrong results. You need to use the other arm. That's the message. You can't take us because you might get this dilution effect and falsely elevating based on what is being infused. Yeah? So that's pre-analytical error caused by that insensitivity or not being careful about the clinical situation facing the patient with an IV going. Yeah? And complaining that they had troublesome IV to say, I don't want to stick the patient again. So be careful with that. What about the one below? I'll take a half a minute again and we'll talk about the one below. Delayed separation. Right, so as far as delayed separation, let's look at the first one. First analyte, potassium. What's happening with delayed separation here? It's moving up from 4.1, moving all the way up to 6.4. Right, that's an important point. There's somebody again has mentioned does potassium get elevated due to chelation when put in the ED? Well, remember that's one of the possibilities of pre-analytical error. Wrong tube. If you put it in a potassium EDTA tube, it will be elevated immediately. Nothing about delayed separation here is different. Now, notice, so you need to put the sample in the correct tube. So that's a very important point again. If you have it in the wrong tube, we're going to put it in a potassium EDTA tube, potassium will go. Right? But in this case here, we're just talking about a red top tube which has no anticoagulant in it. And the blood is sitting in a red top tube. And the potassium level is actually increasing. Yes, hemolysis can increase the potassium. Very important point. Very important point. But what happened? But let's finish potassium story. Okay. But what happens here is not hemolysis, which can increase potassium, but potassium actually leaking from the cells because this is delayed separation. Right? So as you move from 0 to 4, 8, 24, you find that the potassium is actually leaking. In other words, this is the real world scenario is that the patient has taken blood for potassium in a red top tube and then have have it sitting on the desktop. You have it sitting on the desktop. And over time, in contact with the serum, and over time, the potassium leaks and leaks and leaks to the cell, and you get a high potassium. So what the take-home message here is that if you're getting blood for potassium done in a red top tube, as it reaches the lab, you should, once you have a good clot formation, so that's point one. Once there's good clot formation, and let me sidetrack a bit there, good clot formation, you know that because the sample has been clot retraction, and you normally have the sample sitting at least for 1 hour, right? So that's important, right? So what happens there is that you actually have to, over time, watch, and then the potassium actually increases because it's in contact with the red cell after about 6.4 at 24 hours. So the take-home message here, you need to, once it has passed good clot formation, you need to separate, and you can then store that serum in the freezer, and then you can analyze. Once it's left on the desktop overnight or for any delayed period, you're likely to get falsely elevated potassium. And as I said, you don't treat the results, you treat the patient. Okay? So if you have a result that comes back, your potassium is all like 10, 11, 12, okay? Immediately, you know something is wrong because at that level of potassium, patient will be dead. And you have the patient in front of you. So whenever the result is not in keeping with the clinical picture, your next step is to repeat. Don't treat. Because if you put potassium 9, 10, and you start to treat, you can send the patient into hypokalemia and kill the patient. Okay? If the result is not in keeping with the clinical picture, then you need to repeat that blood result. And that's the key thing. Repeat the sample. And then before you decide. Somebody asks us, why is it for the dip in the first 2 hours? So these 2 people. Isn't the potassium lethal? Yeah, correct. Exactly. It's lethal both high and low. So that's why if you see a result come back at potassium high, you know that in your mind. So therefore you know something's wrong. That's not a real result. You gotta repeat the result. Yeah? Remember, the result must be in keeping the patient, not the other way around. The patient is keeping the result, right? That's the important part. Right. Well, I remember these are real life values, real life situations. What we look at as trends, sometimes you may actually add it to, and you may have some sort of contamination or something like that, or dilution for some reason, which should happen actually. Okay, so these are things, our error even in measurement. Okay, they may be analytically. Remember, it's mean plus or minus to standard deviation. If you actually did the sample 3, 4, 5 times, you may find there may be no difference between the 0 and the 2 hours. Yeah? And it starts to go up. And we'll see this in other cases as well. But the overall trend, that's why you do the best fit, okay, to see what is actually happening here. And look at the glucose. So I think I addressed the lethality there for potassium. Yes, but in fact, potassium is lethal. It's used as one of the cocktails in the execution chamber, isn't it? You have your sedation, you sedate the patient. You also have your muscle relaxant, and then you have your KCl, potassium infusion, which stops the heart. Okay, so it is lethal. Yeah, so therefore, so you need to appreciate the range for potassium, and that's why you need to check in patients just to reinforce. You need to monitor if someone is actually a patient who actually has diarrheal disease, okay, or even in ketoacidosis. You need to be able. In ketoacidosis, you need to be able to actually monitor the patient in order for you to potassium to treat. Okay? Because abnormalities in potassium can actually kill the patient. So if you ketoacidosis, the potassium is going up, you need to treat that. Diarrheal disease, the potassium is going down, you need to treat that. Yeah, because high and low potassium can kill. So you must monitor potassium. Potassium is one of the critical ones you need to know. So look at the A1, because remember it's still responsible for A1 electrolytes. And this potassium here story will fit in quite nicely with your potassium in terms of how you feed potassium, whether it's an emergency or chronic state. Okay. Not just you wait for too long. You don't wait at all. The time you wait for is actually just 1 hour, so that you get a good clot formation. Once you have clots, you separate and you store, and then you can take your time and analyze. That's the point. Glucose, well, wait, I think everybody knows what's happening with glucose, right? That's why glycolysis is taking place, so it's dropping blah 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 from 6.3, 3.9, 3. Okay, so that's clear. But again, use your common sense. If you have a point clear instrument that our fingers stick, then this matter, isn't it? Yeah. This is active using a tube, and that's why you need to have your fluoride and your oxalate, isn't it? Yeah. So if you don't have fluoride and oxalate, look what's happening here. The red cells using glycolysis. Yeah. So we can move on. You see, effect of tourniquet, we have one after that. Okay, so let's look at the other one, pre-articular effect of tourniquet. Correct, right? Good. So effect of tourniquet, I'll keep quiet for another minute or so. And then we'll come back and discuss the effect of tourniquet. Remember, all of these are pre-analytical errors, so you should have in your mind a list of give samples of pre-analytical error. Yeah? So you can think of, even from the laboratory request for wrong patient, wrong tube, as someone mentioned with potassium EDTA, for example, right? And then those are the 2 conditions, delayed separation, whether it's your potassium or your glucose, yes? Or taking blood from arm with IV infusion. All of those are pre-analytical before analysis. These things affect your result. So I'll keep quiet for a minute and then come back and we're going to talk a little bit on the tourniquet. Okay, so let's move on. Here's effect of tourniquet. Notice the tourniquet on. I hope you can actually see this. Maybe I can just see if I can zoom in a little bit. Okay, hopefully that's a little better. Effect of tourniquet 0.51234 minutes, and then taking it off. If you notice here for the calcium, these values, general trend is then increasing and then decreasing, right? Even though the general trend here is increasing, the session protein and then decreasing, albumin and hemoglobin. So basically, tourniquet on, you have an increase in your calcium, your proteins, and then after the tourniquet off, it goes down. The message here is that once you have a tourniquet on, the one word explains this. Okay? One word explains this. It's hemoconcentration. Hemoconcentration. So make sure you get that down. Hemoconcentration. And they explain that once you have a tourniquet on, you inhibiting your venous return, yeah, increasing your venous pressure. So small molecules, they're talking about things like water, leaves the intravascular compartment, and the larger molecules, the things that protein stay within your intravascular compartment, and the value increases. Yeah. Well, so calcium. The thing about calcium is that actually calcium is actually bound to protein. Calcium is actually bound to protein, and hence it actually increases. So let me just take a few and see. Tell me what happens when the tourniquet actually comes up. Take a minute and think about it. Okay, so you see what's happening here. When tourniquet off, what happens? It actually comes. Let me just read the chat. Normal blood flow returns, and not protein moves out. Protein stays in because it's big, but it becomes diluted. Okay, because when the tourniquet is on, water leaves and protein stays in, and hence you get this concentration of proteins. Calcium bound to albumin, so hence it goes up. Once you release the tourniquet, it comes back down because now the circulation is back to normal, so the hydration level within the intravascular compartment returns to normal. So you get water staying in now because pressure is now coming down. So that's what happens. But protein doesn't leave because it's of the size. Right? So in other words, the message here is that if you're taking blood for calcium, you put on a tourniquet. Notice this is not in any notes. You put on a tourniquet. So we have increased venous pressure, you have your dilated veins, you get a needle in the vein, then you release the tourniquet, and then you withdraw blood. So that's how phlebotomists take blood for calcium, to avoid this hemoconcentration effect. Okay? Tourniquet on, the veins become prominent, you get a needle in the vein, and then you release the tourniquet, and then you take out blood. Yeah? So don't forget that procedure. Because of this hemoconcentration effect of tourniquet. So that's the practical message here. So you can see it's pre-analytical error if you don't take blood properly for your calcium. Good. Right, so let's move on. So we can wrapping up now. We cross the midpoint. Causes of hyperkalemia. I'm just in my layman's term, I says this is a sort of a non-medical, non-clinical issue here, more lab issue. hemolysis, some people mentioned that already. Wrong specimen tube, somebody mentioned that already. Okay, prolonged tourniquet, fingerprint, all of these may have, like, for example, heel and fingerprint collection. You're actually milking the blood, that can cause hemolysis. Delayed separation, we went through that, right? Get back down to normal. Right. Other points to note, if you can pre-article error, I mentioned this already for arterial blood gas. If you're doing an arterial blood gas, make sure it's an artery, not a vein. Fasting, I mentioned that as well. Some people say they fast and they take nothing except water. So you ask the patient, have you been fasting? The patient answers, yes, doc, I fast all night. I didn't eat anything at all. All I had was a glass of juice. That's not fasting. Fasting is NPO, excepting water. Good. Right. And of course, don't expel blood through a syringe. So a needle, sorry, can cause hemolysis. Eh? That's why I use the vacuum system, and you'll see that in your lab demonstration. Right. 24-unit collection. I know you do this in year one. Just reinforce. Please have a list of, because urine is so common, right? When on the ward, make sure you know what examples of pre-article error here, which is like under collection, over collection of the urine. Right? So that's why I brought it up. So go back and review that, how you do a 24-unit collection. Other things you can use a 24-unit collection for is GFR. You can get errors here in your calculation and in your units. Okay, this is UV upon P. This is the volume of urine in mils per minute. So you may have the whole collection done correctly, but if your calculation is wrong, you can get it wrong because your units or because its urine flow was not considered as mils per minute. You can get it wrong. Okay. I mention this because urine is so common, and have other things that you may want to do a 24-unit collection for. So please note, that's note to self. Get some reasons why you would want to do a 24-unit collection. Yeah, one could be like getting an estimation of your total protein content. Yeah, that's one reason. Yeah, one also getting a total urine volume, a GFR as well. Okay, so you may also need to do that, or cortisol, 24-hour urinary free cortisol. So those are some important reasons why a physician may order a 24-unit collection. So that's right. It's not listed here in the notes, but that's a little something that you already have. You know, get some reasons or why a physician would order a 24-hour unit collection. Maybe just to get an idea of whether somebody, you know, is the urine volume or urine output in the 24 hours, right? It could be as simple as that, or total protein output in 24 hours. Yeah? Or total cortisol output in 24 hours. Those are some reasons. Okay, back to the sample collection. You'll see this in your lab demonstration, 24 basic urine sample collection, and I'll come back to this. Sample container is clean, no detergent, sterile, and you must have proper labeling. I'll come back to this when you actually have a picture of the sample container, or maybe I will include one going forward in this presentation. Yeah. So usually your samples for MSU for CS, that means it's usually a sample for microbiology. It's the first sample anyway. MSU midstream urine for CS for culture and sensitivity. And that container obviously has to be sterile and proper labeling, and it's obviously clean and doesn't have any detergent or disinfectant there. Types of urine collection, midstream catheter specimen superpubic, you're familiar with this. Midstream, you're familiar with that from year one. What's the most important thing about midstream? Just to remind yourself. Everybody knows how to do midstream, but sometimes if you get asked in a clinical scenario, they tend to forget the most important thing, which is what? In collecting a midstream. Main thing is clean area. So the purpose of doing a midstream is to do a CS. MSU for CS, midstream urine for culture and sensitivity. So you need to demonstrate that you know the purpose of the midstream is to get a clean catch specimen. So the first clean area, one, then the first part of the stream is part of the middle of the stream, right? It's all part of the whole process to get a clean catch specimen. Suprapubic and then catheter specimen. Suprapubic is the cleanest in the sense that it's supposed to be a sterile procedure to get a suprapubic, usually done in infants. Yeah? Midstream, which one to repeat? Midstream or suprapubic? Oh, I'll break them. Okay, fine. Let me just, okay, I missed focus. I was mentioning midstream. Okay, so for midstream, as I said, midstream urine, time you say midstream, you should be thinking clean catch. Clean catch. Meaning, so that's why the first thing you do for midstream is you have a clean area. So you demonstrate, you know what the purpose of doing this particular type of collection. So you clean the area first. That helps you to get a clean catch specimen. Then you pass the first bit of the urine and discard. and then you collect the middle of the stream. Yeah, because midstream urine is usually for MSU for CS. Midstream urine is midstream urine for culture and sensitivity. You want to be able to do a culture, so you want to get as clean a specimen as possible. So that's what's important about midstream urine. Suprapubic is very clean, and then it's supposed to be a sterile procedure as well, usually done in infants. Okay. And catheter is the one that's the most unclean specimen because you may get a lot of contamination there. Yeah. So those are type of collection. Then you have collection times: first morning, second morning, spontaneous, and 24. We did 24. Spontaneous is any time. What's so important about first morning urine? That's the one to remember. First morning urine is due to or important for doing things like pregnancy tests, because you have to be, that urine is concentrated. So you most likely pick up a positive earlier when you do first morning urine. Yes, concentration. Right, a few points about urine collection that is important to keep in mind. All right, so the first one is, if it, and that's way on top here, normally you should do the urine should be you should do a dipstick right away. Right? You collect it in your container, and you're going to do pour some for dipstick, pour some for MSU for CS. Do it right away. But if you cannot do it right away, then you need to put it in the refrigerator. Okay, if you can't do it right away within 4 hours, as close as possible to that. Put it in the refrigerator, and then you can do the analysis later. Yeah. Key point, as mentioned in the slide, put it in the refrigerator, not the freezer, because freezing destroys the cellular elements. Yeah. So key point, having put it in the refrigerator, you need to remember when time comes for analysis, you need to take it out and let it warm up to room temperature, because what happens when it's in the refrigerator, it's temperature affects rate of reaction. Okay. So you may get a false negative if you don't allow the sample to warm up to room temperature. Yeah. So that's urine collection there, and of course, reason for not putting it in the freezer, you destroy the cellular elements, and reasons for doing it right away. If you don't do it right away, you may likely get things like increase in pH, increase in germ count, degradation. Let me explain increase in germ count. Typical example I use every time is if you have a diabetic patient, and diabetic patient has a few bacteria in the urine. If you allow that urine sample to sit on the desktop, and for any length of time, what you might find happening is that you actually get, that's a good culture media, and you have increase of multiplication of the bacteria, and then you can get a false positive and diagnosis of UTI. So the patient really does not have a UTI, but because the urine has been sitting there, bacteria, glucose, and sitting at room temperature, you can get multiplication. Yeah. So that's why you should actually do it. Don't delay. Right. So that's the germ count, and of course the rest decomposition, oxidation, etc. Right. So I hope everybody appreciate that. Basically, it was very important. This is something you do common almost every day. You walk in a medical ward, somebody has, or even in the lab, somebody is bringing a 24 urine sample. Somebody is getting midstream urine, checking your glucose content. Somebody has to get a suspected of having a UTI. I need to send a sample out for culture and sensitivity. So that's bread and butter medicine, really. Either in private practice or even on the ward. Right? Right. So just some 2 quick slides. In terms of a 24 urine collection, you would actually see the container. Remember, the container is not, that's what it's not. It's not your Coca-Cola bottle, it's not your 2-liter bottle, which you might see sometimes, because we're running out of, bottles. Right, you're running out of bottles, but the container is actually a dark container to protect from light. And these 2 slides just reminds me to tell you that the container comes empty. That's one. 24-hour urine container is empty. And when you're giving it to the patient, you normally have to add sometimes 10 mils of preservative. Okay, 10 mils of preservative that may be in here. And that preservative maybe you'll see it better in your actual PowerPoint. That preservative could be things like HCl, okay, or boric acid, toluene, okay. So caustic material, substances, liquids, yeah. So you need to tell the patient, therefore, do not, remember you're instructing the patient how to do a 24 urine collection. And you want to tell them, make sure and get all the urine. You're stressing that. The first part of the urine, as soon as you start 8 o'clock, discard it. collect all until 8 next day. Include that. Make sure you get everything. And then you hand them a container and has liquid in it. They are likely to just decant it and throw it away. So you need to tell them that's a preservative. Do not throw that away. You need to tell them do not allow it to splash on the genitalia because of things like HCl, corrosive substances. Okay, so they need to be careful with that. And then you can give them the instruction. You don't need to remember all of these corrosive substances that are present in the container. You simply have to go to a reference text, right? And you'll see if the physician orders citrate, what do I need to include? And it tells you, okay? And sometimes no preservative at all. And again, the reference container will reference book, textbooks will actually tell you that as well. You see? So none. And a lot of it is a lot of HCl and you have toluene, etc. Okay? So the point about the 24-hour urine collection sometimes needs to have a preservative in there depending on what analyte you're collecting or testing for. That's the take-home message. Yeah? And you can check reference textbooks for it. All right, so let's wrapping up on the last 2 slides for this morning. A little bit of point of view. I think we mentioned this in year 1. Okay, so hopefully you can go back and read it just to remind yourself about it. This list of tests is the same as I had in year 1 for 2 years ago, but I'm sure it's getting bigger, larger. Right? So you can actually include, as technology improves, I'm sure by now, just to reinforce it's near patient testing. So if you have it in the ICU, or you can have it in the outpatient clinic, so that's clear. Or you can have it in the emergency room. Okay, so that's no problem there. And just again, I did this in year 1 already, so just reinforce points that you tend to forget is this one: benefits the physician, improve therapeutic turnaround time. So don't forget, turnaround time is armed report, time taken between the blood sample is taken and time you get back your report. So that turnaround time should be decreased. Once it's decreased, it's improved, it's shortened. Yes. So the patient gets results better, faster, and hence can actually possibly translate into better, more immediate care for the patient. Right? Important point is patients, less traumatic. Okay, fine, convenience, yes, you can have it even in the pharmacy if you want. But this point here, less blood drawn. Okay, key point. Blood drawn usually can lead to, frequent blood draws can lead to the iatrogenic anemia, depending on whether you're an infant or adult. If you're an infant and you're having a lower blood volume, total blood volume, adult is usually over 5 liters, lower blood volume, then, and you're having frequent blood draws, you can actually cause anemia. So iatrogenic anemia is anemia caused by physician intervention. So the patient is ill in hospital and the medical management dictates that you actually should have frequent blood draws to monitor the progress of the patient. That procedure in itself can lead to anemia, and that is called iatrogenic anemia. So what is suggested is that a point of care system where you're having small ones that may actually help reduce the likelihood of that happening in that condition. So to the lab, increase visibility, of course, collaboration, that's good. And then, yeah, the main advantage to the administration is financial, short stay in the intensive care unit, for example. And I use that as an example because of cost, right? Financial savings. If you get back your blood results and you can make decisions about patient management in short order, then that patient you can save a patient 1 extra day in the ICU. Right? And if you are paying out of pocket, or the government paying us, whoever's the payer would appreciate having less output and get the same amount of management for the patient. So the cost is good. One of the contraindications, so the cost and cost, one of the contraindications also cost, meaning that cost may be high. Cost meaning cost of the equipment. Yeah, if you have one equipment doing 1 or 2 tests, then the cost is high. As against the larger equipment like the vitreous or the in the core lab, which can do many, many tests, that brings down the cost. Okay, so there's 2 aspects of cost with respect to point of care. That's my last point this morning. One point is that cost can be decreased because that's cost to you, the individual, or the patient, whoever is paying the patient's bill. That cost can be decreased if you have a point of care testing system that facilitates you having a shorter stay in the intensive care unit or in the hospital as a whole. Then your cost, your bill, will actually go down because it's taking a shorter time. However, point of care also can increase cost in terms for the laboratory services if your instrument just can only do a few tests. So now the cost per test will actually go up. So it depends on which side of the fence that you're actually on. Okay, so as I said, so that's your overview as it were of your pre-analytical error lecture. So just to remind you, go back, listen to it again if you want need for revision, and go back and look at your water electrolyte lecture. So you can add that to your, we won't go into that as such, but you add that to your responsibility in this lecture, because we don't teach that full lecture in year 3 because you've done it already. Okay. And also I would mention, I'll put on PowerPoint, which is also already up on my learning, overview of the topics that you do in the clerkship. And I'll just mention that on next day. Yeah. Good. So I think we are done. We almost 11:30. So any questions here? Or you can have to look at it on my learning and have questions for next time if you wish. Okay, nope. Okay, so I guess maybe now Anita's still here. She can have the now close the session, and I'll see you guys. Yes, the schedule is actually on my learning already. I mean the topics. And what I want to do, it's not on PowerPoint, so I can bring it onto the system. So I actually go through those topics that we have to cover, that we will cover. And I will meet you on Monday anyway. On Monday, yeah. But it's already in my learning, all the topics. Yeah. Okay. Okay, yeah, thanks everybody. So and I'll see you guys on Monday. Of course, you have class on Friday, but at least for clerkship it's used. Okay, thanks. That now leave my session.
All right, no problem. Don't forget to take off your PowerPoint.
No, yes, let's see if I can share screen. Oh, is it here? Stop sharing. That's it?
Yeah, that's it. Right,
Okay.
so I'm leaving, I'm taking off the session now.
You can close